ASPPH presents webinar, Policy and Advocacy in Support of Academic Public Health Education, Research, and Practice, featuring Mike Stevens, ASPPH Senior Director of Policy, and a representative from the ASPPH lobbying team at Cornerstone Government Affairs, Mark Miodowski. This webinar is the first of the 2014 ASPPH Presents monthly series, which has been designed as a service to SEEP-accredited ASPPH member schools and programs of public health. While you are in listen-only mode and your lines have been muted, we encourage you to ask questions throughout the presentation by using the chat box. We will address your questions throughout the presentation and also at the end of the presentation. Please be sure to refrain from placing your line on hold during the webinar. Additionally, this webinar is being recorded and it will be available on the ASPPH website in the archived webinar section soon. Now I'd like to invite our speaker, Mike Stevens, to begin the presentation.
Thank you, Sarah. I hope everybody can hear. If you can't, please type in a message on to do this. As Sarah indicated, I'm Mike Stevens. I'm the Senior Director for Policy and Research here at the association. And today we'll be trying to accomplish 5 broad goals, all in terms set in the context of explaining the services which we provide to member schools and programs. First, we'd like to introduce the ASPPH Policy and Advocacy team to you. That is who we are and what we do. Second, we'd like to talk a little bit about why policy and advocacy is important to our members. After that, we'll introduce a bit of the process that our advocacy takes, and then discuss how our association's priorities are determined and what they are for the current year. And lastly, we're going to talk about who our advocacy targets are and who our partners are in our advocacy for more resources for schools and programs. The team is divided up into basically 3 parts. The internal staffing team for ASPPH in the policy and advocacy arena is shown here. I've introduced myself, Mike Stevens. I'm the current director. Prior to joining the association 4 years ago, I had spent 38 years in government service, most of which with the House Appropriations Committee, doing health and education issues. Tony, I believe, is on the call today, but will not be speaking. But I've announced my retirement effective the end of March, and Tony Masacci will be the incoming Director of Policy, Advocacy, and Research beginning April 1st. Tony comes to us after 19 years as the Senior Director for Science at the Association of American Medical Colleges, and prior to that worked at the Federation of American Societies of Experimental Biology, and also had assignments with both the House and the Senate in the Congress. Lastly, in our internal team is Mike Zielinski, who's been with ASPPH now for 1 year as of February. Prior to that, he worked for 4 or 5 years in the electoral process, helping to manage campaigns for people in Congress. The 3 of us are the folks who lead within the association. It's important to understand that we have a staff of about 35 here in the association, and each of those, depending on their expertise, is also available to augment the policy and advocacy team. In addition, however, to our internal staff, ASPPH has a contract lobbying firm, Cornerstone Government Affairs. The contract with ASPPH, between ASPPH and Cornerstone, and now between ASPPH and Cornerstone, entered its 11th year last month, which is very unusual in the Washington advocacy community to have a relationship which stays as solid as it is. But we've been getting extremely good service, and we work very closely hand in glove. But on that, Mark Miodowski, one of the founding partners and the head of the Cornerstone team for ASPPH, is on the line, and I asked him to introduce his team.
Hi, this is Mark Miodowski, and we're very pleased to work with the expanded programs that have joined the ASPPH family. And we've been, as Mike said, working for about 11 years. Our office is across the street from the Capitol Hill complex. We have about 35 lobbyists here at Cornerstone in the Washington office, and lobbyists in about 6 other offices around the country. But predominantly we're DC based, and I head up the health team. We work a lot on public health programs. Some of our other health clients include ASTO, the Association of State Territorial Health Officials, who work as strategic advisors for the Gates Foundation, for the Robert Wood Johnson Foundation. We have very close relationships with the CDC leadership and center directors and vision directors, as well as NIH, ARC, and SAMHSA, other agencies as well in public health. And public health has probably been the lead part of our health practice here at Cornerstone since we started the firm about 11 years ago. And ASPPH, then ASPPH was one of our early clients that we cherish that relationship to this day. Eric Patini, so like Mike Stevens, I came off the Hill, actually worked on the House Appropriations Committee doing health and education appropriations as Mike Stevens did. Eric Patini joined us recently. He was Senator Harkin's staff director on the labor, helping him with his education appropriations subcommittee in the Senate until October when he joined us. So he had been working for the Senate Appropriations Committee on that subcommittee for 12 years. Amy Ford Fitters, another founding partner with Cornerstone, kind of co-leads the health practice with me at Cornerstone. Max Canner is our legislative assistant who supports the core health team here at Cornerstone. So we have a bipartisan, bicameral team of lobbyists here at Cornerstone, both House and Senate, staff directors, chiefs of staff of personal offices, and as we need additional offices to go into, we can draw on a pretty deep bench of other relationships beyond this core team of 4 people you see here. We draw on all the other 35 lobbyists, they're at the firm as needed basis to get into certain offices that align with maybe the political relationships that you're looking for within your own delegations. And we've largely been focusing on the Appropriations Committee in the annual cycle of appropriations at CDC and IH, HRSA, that we've seen cuts that we've had to get restored year after year, and then as well as authorizing bills that come up from time to time that we engage on with the authorizing committees, Energy and Commerce and the Health Committee. Thanks, Mike.
Thank you, Mark. I want to emphasize at the end that our relationship from a lobbying point of view is always very bipartisan. We're a 501c4 here to do this, and we are scrupulous to make sure that we are nonpartisan. But Cornerstone is cited in all the reviews of Washington lobbying firms for the quality of its advocacy and also for its very, very high ethical standards. The third leg of our legislative and advocacy team is our legislative committee chaired by Dean Steve Wyatt of the University of Kentucky. We have an internal staff and an external lobbying firm who execute the lobbying strategies. We do not determine it. It's determined by the membership and through a committee structure and the leadership. The committee is currently 21 members. It includes every dean or primary representative who asked to serve on the legislative committee. But in addition, it's constituted in a fashion to have membership from schools which are located in the jurisdictions of key decision makers in the Congress, committee chairman, subcommittee chairman, etc. But so we have an internal staff, we have an external lobbying, and we have a leadership-driven committee to put our policy together. Let's go very quickly through. We have a set of 8 strategic priorities which we review on an annual basis for our policy and advocacy work. They tend to stay consistent, but we do review them annually to see where individual circumstances necessitate a change. Our first strategic priority is to provide timely strategic intelligence. We want our members, schools and programs, to be aware of the critical things going on in Washington which will affect the ability of them to perform their research, education, and support of public health practice functions. Second, we've tried to focus the attention, particularly of the internal work of the association's policy staff, on strengthening the analytic case for the positions we take to the Hill or to the agencies. We want to be evidence-based when we ask for support for our various activities. We do have a naturally occurring partnership, and a very deep one, with a whole series of federal agencies. And because and we'll review this in more detail later on, because we're very dependent on the federal resources which our agencies distribute for research and education, and because they are very dependent on the external university community for training the public health workforce and conducting of public health science, which is important to them, we have a natural relationship, and the association spends a lot of time trying to keep healthy, cooperative arrangements with our agency partners, that is, the executive branch partners. We do, of course, as Marcus just indicated, we advocate, lobby is the other word, for schools and programs directly and through our Cornerstone associates. Wrapping up here, we also manage relationships with public health advocacy partners, by which I mean other associations or national organizations in the public health world. These include the other health profession schools, the national associations of public health practitioners, such as ASTO, NACHO, to do this, as well as a whole series of umbrella advocacy groups that work for public health funding, the Coalition for Health Funding, for example, the Ad Hoc Group for Medical Research, etc. So we manage these partnerships, and we participate in their meetings on a regular basis. It runs throughout all of these priorities, but the bottom line for many of our schools is the association's main function is to protect and expand funding opportunities for them to conduct their critical work. We do have a general workload in which we try to raise public's awareness of schools and programs and what we do in the public health arena. We found that very few people, including policymakers, really understand our schools and what they do, so we put quite a bit of effort into educating them about our capacities and our successes. And lastly, over the last few years, we have paid attention and tried to keep our membership very involved about Affordable Care Act implementation issues, particularly those that relate to the education and research function of our schools. We're not a broad general advocacy group for ACA, but where those things affect directly our schools and their research, education, and practice missions, we follow those closely. But those are our sort of guiding priorities as we move forward each year. So what products does this team produce for you, our members, the schools and associations and programs of public health? They fall into 5 basic categories: strategic intelligence, strategic advocacy, in-depth policy analysis, policy-oriented outreach products, and special initiatives. And I'll give you some examples of each of those. But these are the things that you see coming out of the association throughout the year, particularly at the beginning of the year as the advocacy cycle starts. The first of these here, meeting the strategic intelligence goal, is a monthly legislative report prepared jointly by the association and Cornerstone. It's prepared for the legislative committee, which meets monthly, typically by phone, but at least twice and sometimes 3 times per year in person. And this annual report is circulated first to the committee, but then to all deans and primary reps, and then is posted on the ASPPH website. So this is available as a report of what the latest information is about what's going on in the policy, advocacy, legislative world. We also prepare documents in which we brief the association and its membership. This is an example where we brief the associate deans for research as they met in Portland to do this, and we bring them up to speed so that they're informed. In addition to the report, it gives an opportunity also for us to get the input as to what these legislative and budget proposals mean out in the field. We also produce briefings about the association and our schools and programs for our federal partners. This is an example of a briefing which Rita Kelleher, our Senior Director for External Relationships, and I produced 2 years ago, where we went down to the National Institute of Environmental Health Science at their request to brief them about the public health research which our members do. This is an example of the documents which we prepare, which are used in our advocacy. This happens to be the overall statement of the policy statement for a particular year, which we produce in January, then update during the year. This is used when we visit the Hill, when we visit agencies, and when we visit key players to do this. In addition to the broad overview piece, we'll talk a little bit about specific programs. The center point of our advocacy is a Hill Day in which deans and primary representatives, principally the legislative committee, but also any dean or primary representative from a program, is brought to Washington for a 2-day program of initially briefings to update them on the situation, and then a series of advocacy sessions in which our leadership itself, that is our deans and the heads of programs of public health who are members of the association, go and meet with congressional leaders, executive branch leaders. The advocacy which we do at the national level for the association is not about helping a particular school or program relate to their individual delegation. This is about presenting the national agenda for the association to those people in the Congress who have the most focused leadership responsibilities. We do, in addition to what we do at the national level, support the efforts of individual schools and programs to manage and enhance their relationship with their delegation. That is, the member of the House of Representatives or the senators from their state, so that they can have a good personal relationship with the congressional delegation. But we rely on that largely be done by the schools, either directly by the dean or the primary rep, or very, very often in consultation with the head of government relations for that university or school. And we remind people that many universities have specific policies on the lobbying, quote unquote, or advocacy done by employees of the school in Washington. Wrapping up this period of the presentation, then we'll go to some open questions to do this. We also, as I mentioned earlier, have tried to create a series of documents which state from an evidence-based the policy positions of the organization, or which review key trends which we think are key to our members. The one at the top had to do with the trends in higher education, particularly the cost of education, the cost to students, and the accumulating student debt and default issues of schools. The more recent one done last summer was beginning to look at the issues of changing in the accreditation tools being used, which of course is the basis for all of our membership in ASPPH, which represents all CEIF accredited schools and programs. Lastly, I mentioned we do special projects on a one-off basis. These can vary a lot, but this is an example of the most recent one in which the association has partnered with the Office of the Assistant Secretary for Health, Howard Koh's office at the HHS, to engage in a multi-year effort to advocate for our campuses to move towards tobacco-free status. Our schools are unreasonably safe. Many have tobacco-free policies. Many have smoke-free policies. Some do not have policies. But we'll be working very closely together. And to show these, how these things overlap, we've recently reached an agreement with Senator Durbin of Illinois, one of the leaders in the tobacco-free movement in the Congress, to produce a joint video with the Assistant Secretary for Health, Howard Koh, and one of our deans on this tobacco-free campus initiative, and that'll be used by our schools and also by our national organization to advance this purpose. But I'm going to take a quick break here and ask if there are any questions. And Mike Slowinski from my staff, I think, has any of the questions that may have come up during this period or that may have been submitted in advance. We'll take a break, and then we'll go a little bit and look about in more depth the question of why this advocacy and this policy work is so important to our schools. Mike, any questions?
Sure. We have one here, which is that this seems like very high-level advocacy, but what do you do directly on behalf of students?
Our advocacy is focused on the support to our member institutions for their research, for their education, and for their support of public health practice activities. But beginning about 2 years ago, the association began to focus more directly on student concerns, and in particular the issue of the rising amount of student debt. A policy paper was produced on that, which is available on our website. The association has then made a specific effort to try to resurrect a program of traineeships for students, which had languished over the last few years and in fact was eliminated last year in 2013 as a result of the so-called sequestration of federal funds. And we were pleased to see that we got $2.5 million back into the 2014 budget to restart the traineeship program. That is a small start. We're looking for students to try to be helpful in the case of student aid and seeing if we can get some support for them for what is a very substantial investment to get their public health education. In addition, we're trying to create more information that is the evidence-based about career opportunities for our students by conducting a new organized survey of student outcomes, looking at where they work, what their incomes are, what kinds of activities they're doing after getting a degree. So this is a relatively new activity on the part of ASPPH. but it's one of which that I think will grow over the next few years to try to get more resources and to make sure that we're providing the value for them which they deserve. I think we'll move on here. Our goal, by the way, as we break here a little bit, is to have about 30 minutes of presentations, and then we'll leave the remainder of the hour open for any questions which people have. Turning to the sort of second stage of the presentation, this is a chart along with the next one, which is intended to give a little details about why our advocacy is so important to member schools and associations. I have to say as a caveat at the beginning, the numbers which appear on this and the next slide are for schools of public health only in 2013, the year that finished last September 30th, that is the federal fiscal year. We do not yet have the organized data from programs who just joined beginning in August, but by this time next year we hope to have combined data for schools and programs. We do not think in terms of the percentages, however, that it will change dramatically, because we know as we've merged together as schools and programs that we have some programs that have very large research portfolios, some in the 100 million range. We have schools that have relatively small portfolios in the research range. So we think that this data will hold true for schools and programs, but right now the caveat is currently it's only schools. But what this chart shows is the grant funding which goes to schools of public health in 2013, and this grant support constitutes a very large portion of the total operating grants of our schools. It is by far the largest single source, much larger than state support and state scores, much larger than foundation support, and much larger than tuition. Tuition, for instance, runs about $350 million a year in total for all member schools and programs, and as you see, the grant funding is about 1.1, really, we believe closer to 1.2 billion, so almost 4 times as large as tuition support. But this chart is also indicated, gives us a way to organize our advocacy to show where the most important federal partners are in terms of money. You see NIH is by far the largest, approaching $900 million of competitively awarded grants going to our schools last year. CDC and HRSA are our next partners at over 200 and over 100 million each. And then smaller amounts in a variety of agencies. The other federal includes a whole series of people that we get small amounts from to do this. But as you look at the pie chart, you'll see really NIH is dominant, CDC and HRSA next. So our HHS relationships are important. But sometimes small money can be very important. For instance, the money which we get from EPA is critically important to 3 or 4 of our schools that are very heavily engaged in environmental health research and work. This is a little bit of another version of the same data, but it shows over a 3-year period of time how the budgets have played out to schools of public health. And you see again here the biggest are NIH, CDC, and HRSA, with smaller amounts down the road. One of the important things to look at this chart, we use these as rough justice measure of the effectiveness of our advocacy. NIH, for example, you see us going from 798 to 855 to 864 million in grants, 2011, 2012, and 2013. What's really very impressive in this is the last bar, 2013, which is the gray line, in which our funding actually increased by about $9 million, or roughly 1%, during a year in which NIH's overall budget declined by over 5% as a result of sequestration. We really expected this to potentially decline, not insignificantly, so I think the value of our research at NIH is demonstrated by the fact that it grew even in a very rough year. Just a little bit of perspective here, and maybe it's details beyond what you need, but the amounts for the Centers for Disease Control, CDC, and HRSA include what are called pass-through funds. These funds are given to the agencies to pass through principally to the PEPFAR AIDS partnership countries. They don't actually say it's not activity there to do this, but for both HRSA and for CDC, about $100 million of these amounts, rough justice, are PEPFAR pass-through dollars. So these amounts are roughly $100 million less to do this. But this gives you an idea of just how much resources come out of the advocacy program in our partnership with these agencies. This shows at a more micro level the specific things we look at left. The details of this chart are not critical, but you'll see this chart in every monthly legislative report and every end-of-year report on our policy success. These are the items that in a particular year we follow the most closely, where we focus our advocacy, public health training centers, public health traineeships, prevention research centers, preparedness centers, the two categories of NIOSH centers and NIH. Big picture-wise, this shows the 2014 picture. The last column, 2015, we won't know until the next 2 weeks to do this. But the bottom line of this advocacy for 2014, you don't see the President's original proposal here, but it's important to note that the final 2014 numbers in the omnibus appropriation bill enacted in January restores over $70 million of reductions proposed in the President's budget for 2014 a year ago, February, and in fact provided about $14 million of increases over last year's level for several of our programs. This is not all good news. We were not able to restore the entire amount that was sequestered in 2013 under the Balanced Budget Act to do this, but we feel we made very good progress and look forward to making more progress in 2015. I'm not going to go through it. We have a series of charts here which show for some of the centers program a little bit of detail. I'm not going to go through this, but in each one of them, these will demonstrate a little bit about why these programs are so important to our schools and programs and why we take them more seriously. The first of these are the HRSA Public Health Training Centers. There are 37 such centers currently. 36 of them are located at members of our organization, that is schools or programs that are members of ASPPH. These grants average about $600,000 apiece, or have historically, but we expect a new competition this year, and we're working with the agency to see what that might look like. We know that it's likely that the number of centers will be reduced. Traineeships, as I mentioned earlier, is an area which we're trying to resurrect and grow. We're pleased to have $2.5 million. We expect there will be a new competition and a new structure of the traineeship program announced probably in April, and a competition to be carried out this summer for awards to support the 2014-2015 academic year. Again, of the 46, let's see here, of the 46 awards that were made for traineeships in 2012, the last year for which we had complete information, 23 were members of our organization. I want to step back. I'm not positive that number is correct, so we'll look to correct that. At CDC, the Prevention Research Centers, which have just announced a new competition, have reduced the number of centers from 37 to 26, not because of money, but because of wanting to have a smaller number of more robustly funded centers. We had a call yesterday with the PIs from the various center programs. This is an area of deep interest. But as you see, of the newly awarded center grants, 26, they're all members of ASPPH. And of the 37 that were in the original pool, 34 of them are members of ASPPH. So we compete for these funds. We're not the exclusive group that are eligible to compete, but as you see, our associations benefit enormously from these and really dominate the agency partnership in these areas. There are two sets of NIOSH centers, the Education and Research Centers. Our members are 17 of the 18 such centers, and the newer Agricultural, Forestry, and Fishing Centers, and 8 of the 10 existing centers in that case are members of ASPPH. The preparedness centers, which were established after 9/11, all 13 of these are located at schools of public health. They've been funded at approximately $8 million for the last several years. They're proposed for defunding, that is to terminate the program in the President's budget, and have been for the last 3 or 4 years, but they've been continued under the omnibuses and the continuing resolution. This is a part of an overall restructuring of how the federal government delivers services in the Homeland Security arena. We expect this to be a fight again this year. Lastly, this chart just shows the history of NIH funding. The important thing to understand is that big picture, these are millions of dollars, or basically billions, is that over the last decade, NIH has been relatively flat funded after seeing very, very large increases in the 5 years prior to this. It has meant a very, very difficult and competitive situation in NIH where less than 1 in 5 approved grants are funding. This is an area where we've tried to increase the presence and the visibility of population-based and prevention research at NIH, and that may have borne some fruit, as this year, last month, in fact, NIH issued a new strategic plan for prevention research. ASPPH has been involved in that in its creation and will continue to be involved in its implementation. I'm going to break, and before we go into sort of the last section of this, and just check to see if there's any questions that have to do with a particular partnership or the agencies or the programs we work on.
Yeah, we actually have one question about prevention research centers, and they said the new awards were around recently and that there may be some changes going forward, if you could speak to that a little bit.
Yes, as mentioned, this is a topic of very high concern. Right now at ASPPH, we held a telephone call with the PIs yesterday, and which Steve Wyatt, the head of the legislative committee, chaired. The awards were announced last Thursday, February 20th, and even though the money stayed roughly the same as last year, about $25 million, the agency made a decision to reduce the number of centers from 37 to 26, and because they added 3 brand new centers in the competition, 14 existing PRCs, which have very strong track records, were terminated. There was a factor about geographic distribution, but this is an area in which the association is looking at options, trying to gather additional information, and will be taking up in the next couple of weeks what the position of the association should be. There are a variety of options available to us, but we need to understand a little bit more the logic behind CDC's decision to reduce the number of centers. It was not budget-driven to do this. Also look at the geographic distribution areas, but mostly look at the degree to which how additional resources might be used if they can be found, and finding additional resources will certainly be one of the issues on the board as the association puts forward and decides its advocacy priorities for 2015. The last phase of this presentation really looks at the process and the targets to do this. This slide, which we call the iron triangle or the pink triangle slide, is a sort of reminder that the way that the federal partnership works is a codependency among 3 major generic players in terms of the Washington relationships. The iron triangle metaphor was created by President Dwight Eisenhower as he left his presidency in 1960. In his parting remarks, it was intended to describe the dangers of the iron triangle in terms of the defense industry, the defense sector, in terms of the relationship between defense contractors, the defense committees of the Congress, and the Department of Defense, and the uniformed services to do this, which he felt often worked to the contrary interests of the overall country to do this. We'd like to think we have a much softer, more beneficent triangle, but we also have the same sort of codependency between the agencies we deal with, HHS, NIH, HRSA, CDC, AID, EPA, et cetera. The committees in Congress, particularly the appropriations committees, but also the authorizing committees who create programs and set their overall parameters, and ourselves and other advocacy communities who represent the people who do the work. So whenever we're approaching trying to accomplish what we want to do for our members, we do it in the context of there being a partnership with the Congress, a partnership with the agencies, and in collaboration with our advocacy partners. We have a calendar against which we work. I won't go into the details of this particular chart, which shows the overall budget cycle to do this. But Congress is organized in 2-year segments when the elections occur, and within that, in 1-year legislative sessions, our advocacy and our priorities are set to reflect these 1-year legislative sessions. And the last several years, they've focused like a laser, 90% plus, on the issue of federal funding, because Congress has not, since the Affordable Care Act, really been enacting much substantive legislation. But our process really begins with submission to the President's budget, making our case to Congress, following congressional action, hopefully following their completion and enactment, and then this year up to an election day. But we do have a cycle of activity that begins anew every year. It allows us to refresh our policy positions and to re-energize and refocus our advocacy. Who are our advocacy targets? First of all, it's going to be the spending committees in Congress. This is the House Appropriations Committee. It has several subcommittees that we care about, but principally the Labor, Health, and Human Services and Education Committee. I won't dwell on this on each chart. To do this, this shows the leadership, but the colored rankings on this chart show members of the committee who either announced that they're running for other office or retiring and therefore won't be here next year. And you'll see a lot of colored spaces as we move through here to do this, which means there's going to be a lot of turnover on the committee next year, and we're going to have to spend a lot of time looking at new champions. So I mentioned we also look at the House Authorizing Committee, in this case the Energy and Commerce Committee, and in particular several subcommittees, but particularly the Subcommittee on Health. Again, lots of retirement. The Senate side, we have a two parallel committee structure, Senate Appropriations. Barbara Mikulski, who's a favorite of mine, who I work with, albeit from the House side, who's tried to re-energize the appropriations process, and I believe is given singular responsibility for getting an omnibus bill enacted this year because of her drive and her commitment to regular order in the process. And then again, the Senate Health Committee. You'll see here, we won't, as I say, go into the details, but the retirement of Senator Harkin, who's both chair of the full Health Committee, which is the authorizing committee, as well as chairman of the Labor, Health, and Human Services Subcommittee, is going to leave an incredible hole to be filled in terms of leadership in the Congress on public health issues. This chart, again, we won't go through all of these, but again, a reminder of our relationships with the executive agencies that we manage along with the Congress, particularly strong on HHS, but also USAID, EPA, FDA, DA, et cetera, to do that. These are just a few of our advocacy partners, the Coalition for Health Funding, which is an umbrella organization for all public health programs, for funding. Research America, a big national organization in support of the research mission, particularly NIH, but other agencies as well. Trust for America's Health, ASTO, NACCHO, the other health professions organizations, the American Public Health Association. These are people who we informally coordinate our activity and support each other in this effort. That concludes the sort of formal element in the presentation. We'd encourage any other questions that people have. Please type them in the field. Again, I'll talk to Mike to see if there's anything in particular that we want to do as a wrap-up question to do that.
Sure. We have one question come in, and just sort of looking at all those numbers, what are sort of the biggest budget threats and also opportunities for schools and programs of public health?
Well, I think, let me do, broadly speaking, let me say that I think that the changes which are taking place in the healthcare system in the United States under the Affordable Care Act create the largest pool of opportunities for our schools, particularly in support of public health practice, but also research and education. The advocacy work which we do is not so much around that, but what's going on in their communities, in their states, is something that they should really be paying a lot of attention to as the Affordable Care Act becomes a reality. But in terms of opportunities and risks specifically, unfortunately, the difficult fiscal times which we're in, the attention to the deficit, the large debt problem that this country has to deal with, has caused even what are perceived to be friendly administrations, a Democratic administration under President Obama, to propose lots of retrenchments in support for programs which we think are really important. The most critical of those are proposals now for 3 years in a row to eliminate a variety of centers programs, particularly the NIOSH centers at CDC and the preparedness centers at CDC, but also significant reductions in the Public Health Training Center program, which they have previously supported. So I think there are risks which we're always going to have to fight against that for purely overall budgetary reasons, good programs could end. In terms of opportunities, we do think that the sort of myopic view on deficit reduction and on debts is letting up a bit, and the need to do some new investments is going to be emphasized, we'd like to think, in the next cycle. We think there's an opportunity certainly to reverse some of the proposals, negative proposals the President's done, but also to grow support in areas like traineeships, which saw a bit of a resurrection, potentially for public health training centers, which we think is widely supported within HHS and the Health Resources and Services Administration, if we can just get some additional resources to do this. But I think the other place which represents an enormous opportunity is the potential turn of NIH itself towards a enhanced focus on prevention and population-based research. The proof is still out on that, but the adoption of the new strategic plan for prevention research we think represents a real opportunity. In addition to that, NIH has reached out to us to conduct a survey of our research faculty people to determine research skills so they can increase the number of our people serving on NIH peer reviews. So we like to think there's opportunities to grow the amount of resources which we get within the NIH budget, not just because NIH is getting bigger, but because the value of our research has enhanced recognition by NIH's leadership.
Another question here is, you mentioned and noted that many members of Congress have recently announced that they're retiring or possibly moving into other offices. How will that turnover affect what ASPPH does for advocacy? And as sort of a follow-up, what does that mean for public health generally?
It's a very good question, but with pretty much an unknown set of answers. We're going to see the largest turnover of health leadership in the Congress in the 40 years that I've been involved in public health. I went to a school of public health a long time ago and began my service for the Congress in 1975. But with the retirement of John Dingell, the Chairman Emeritus of the Energy and Commerce Committee, and enormous power in the public health world, Henry Waxman, probably the best-known legislator on the House side in the health arena over the last 30 years, Tom Harkin in the Senate to do this, the retirement of at least 5 Republican subcommittee chairmen of the Appropriations Committee to do this. We're going to see a whole new leadership in Congress, and we see those new leaders being people who have not trained for the job the way that their predecessors might have been. That is, they don't necessarily have the same depth of experience of health issues that their predecessors had. So I think we have an enormous challenge. And if you go back to the earlier slides, you'll see that our advocacy is really focused on those people who are chairman, excuse me, who are chairman and ranking members of key committees and subcommittees. So that's going to be a major challenge. We will see, we believe, some consistency in the leadership in the executive branch, but even there, excuse me, as we get into the 7th and 8th year of an 8-year presidential term, we're likely to see some of that leadership change. So we're going to have a considerable amount of instability in the people we deal with in this partnership. That creates problems, but also opportunities if new faces can emerge that we can bring in to be advocates for our schools and programs.
And it looks like we've had a few questions here that I can lop into one, which is sort of how can students and other people within schools get involved with the policy and advocacy process sort of from where they are?
A good question, and we're very anxious to do that. First of all, I think they should become informed about policy. The monthly reports which we put out, which are posted on our website, are a good way to keep track of things. We are available if they want to bring issues to our attendance, particularly student issues or something to our attention. Student issues are a particular concern, but faculty, researchers, administrators can do that. But in the part of the faculty and the leadership of schools, the most important thing, I think, is the most important things are 2 particulars. First of all, that they establish a relationship with their delegation and their senators. That if a problem comes up in their school, they're not going as an unknown in to ask for help from their congressional delegation. So inviting members and senators to your school to see what is there, to make the case, is critically important. But the second part then is to become active on issues that they really do by bringing them to our attention. We do use our faculty, our associate deans, in particular our deans and our primary program reps in our advocacy. If they want to be involved, they should let us know the issues they care about. We can look for opportunities to build them into the system. I think that's it for questions. Unless other people have anything to add, I'll turn it back to Sarah. But listen, any other questions? I think the answer is no. So Sarah, back to you.
Thank you all for joining us today, and thank you to our speaker, Mike Stevens. As a reminder, the recording of this webinar, along with the PowerPoint slides, will be posted on the ASPPH website soon. Please be sure to contact us with any additional questions, and also to register for the next webinar in the ASPPH event series, the new NIH Strategic Plan for Disease Prevention, which will feature the Director of the NIH Office of Disease Prevention, David Murray. That will take place at 2 p.m. Eastern on Thursday, March 20th. Thank you.
Thank you very much.